pointing out earlier on, injecting those blood thinners or clot-busting medicines throughout the systemic circulation highly increases the risk of bleeding. In order to eliminate that, when you inject it, the clot-busting medicine is contained between these two balloons. And once we inject it, and I'll show this here, hold on to this, and this will go on pretty vigorously here, and this thing starts kind of activating like that, and the audience can see that the catheter is vibrating or torquing pretty vigorously here, and that basically macerates the clot, and that allows us to, and a treatment like this can go on for somewhere up to let's say about 10 minutes instead of as we used to treat 24, 48, 36 hours going on infusing these medicines. Instead, you insert it in the cath lab and treat the patients for 10 to 15 minutes, sometimes longer, and aspirate. It's really a dramatic thing to do.
Interesting.
But certainly the modalities like this, and certainly many other modalities, including POSIS or Angiojet system, and this system, and we have options that are emerging for treatment of deep vein thrombosis. And of course, the goal of treating patients with these modalities is to debulk or remove portions of the clot, whereby using any of the medicines, as you were suggesting, will help drain the rest. And of course, if there is and I have one more little gizmo, which again, here you all can see this, focus on this. This is a filter or a little umbrella-like device. If you can look at this, here, zoom on this. And this is a device that goes into the inferior vena cava or closer to the belly button, typically, or sometimes it can be put in the superior vena cava as well. As the audience can see, it's collapsible. It's inserted through a tiny catheter, basically put in the large vein. If the audience assumes that there is clot in the leg veins, this is put higher up in the pelvic area or actually closer to the belly button. So if a clot indeed breaks loose and goes up, it is trapped in this little basket and cannot migrate up to the lungs. Of course, we are really worried about the clot going upstream to the lungs, whereby it can cause fatal problems. If it is in the legs, it is one thing. It causes swelling, redness, scarring of the veins, and so on. Whereas if it goes to the lungs, so the goal of putting these filters, and of course you can't put in a filter in everybody that's diagnosed with deep vein thrombosis. It is only meant in those patients when you have effectively treated them by some other modality, or and we are unable to successfully get rid of the clot, or if the clot keeps on coming several times afterwards in spite of using Coumadin, or if there is a massive pulmonary embolism or a large piece of clot in the pelvic veins, and the patient has no scope of getting out and recovering, you then choose to put these filters. And of course, there are many types of filters. Some of them can be taken out once you deploy them. Once the acute illness is over, you can go back in 6 to 8 weeks or somewhere upwards of 8 weeks and retrieve the filter once the problem is gone. Whereas in some people, and more often, once we implant them, they stay in the body for a lifetime. So this is purely intended to prevent the migration of the clot in the leg veins going up to the lungs. And all of us do this all the time. But then going on to the next thing, which is the pulmonary embolism, which is the mother lode of all these problems, which is the final consequence that we also dread. Let us assume that they do have a pulmonary embolism. What are our options right now in the current treatment environment?
Basically, pretty much the same as we have for venous thromboembolism.
Blood thinners and
blood thinners, anticoagulants. Again, the patient comes in and we know he has a pulmonary embolism and is crashing, then you try to give them thrombolytics. You can give them systemically, or you can try to get them into the cath lab and give them directly at the point where you're having the problem. But again, it's the same issue. You have to try to remove that clot. If it's a saddle embolus, like that patient we had a few months back where he had a saddle embolus, he was lucky he had flow around that embolus, and he was okay with that. But it really is very limited as to what we can do.
Absolutely, and I think certainly the treatment modalities like the ones that I've shown have emerged, but still a lot of work needs to be done. Right. In spite of the bulk of the patients we are talking about, this is not that insignificant as a health risk to patients. But
Very bad
somehow,
problem.
in terms of treatment of pulmonary embolism, again, we are simply doing the same old thing we were doing 20, 30, 40 years ago. And I'm not criticizing it in the absence of any better interventions besides massive thoracotomy and removing the clot. There isn't one definitive way of treatment of pulmonary embolism. There are many ways to skin a cat.
Unfortunately, not many people make it long enough to get diagnosed, get
and you cannot go to surgery. They're not stable enough to go to surgery
to get to the cath lab.
It requires a thoracotomy, exposure to the pulmonary artery, and plucking out that clot because it's so massive. So there is a lot of work that needs to be done in treatment of pulmonary embolism or clots in the lung veins as well. So suffice it to say, still, unfortunately, once we commit them to Coumadin, almost all of us are worried about stopping the Coumadin. So once a 40, 30-year-old guy gets a pulmonary embolism related to it, they're committed to it. All of us see it. He's 50 years old. He says, I had an accident 20 years ago and I'm still on Coumadin because nobody has the guts to go and stop the Coumadin because they're worried. There is no second time. If the PE happens second time, you don't know what's going to happen.
That's right.
The patient may end up being dead. So it's a very complex problem, and I don't think we can do a great deal of justice to it talking about in an hour or less, but we are trying to shed some light. And let us just kind of go back and talk about more of the long-term consequences of deep vein thrombosis, including thrombophlebitis and venous ulcers and all that type of problems in the leg veins.
Well, one of the things I was referring to earlier is the clot getting in the vein and stretching the vein. Even if through medications or intervention we're able to get the clot removed or debulked, or over time the body lyses it, the clot in the vein opens back up. Now we're left with a vein. Veins have valves in them. They don't flow like arteries where the blood is actually pumped through with force. The veins are very pliable and the muscles around the vein squeeze and the blood then moves up the column of the vein, and then there's a valve that closes to keep the blood from going all the way back down to the foot. And as this vein gets stretched, the valves no longer meet and overlap. They're like this, and then the blood tends to want to drain all the way back down, and it's much more difficult to get the blood back up to the heart. And that's where the chronic swelling that we worry about, the post-phlebitic syndrome that's so ominous of a large DVT, is that chronic swelling that is so hard to get rid of, because once that vein is stretched and incompetent, it's very, very hard to keep that extremity from swelling.
Absolutely, and then as you correctly pointed out, that this is far more nagging problem, some of the arterial problems we deal with every day, that we so talk about in many of our shows, because once the clot is in, if the veins and if the valves are destroyed and the veins are fibrosed and scarred, sometimes completely blocked, although the venous system is a very complex network draining into the superficial veins and so on, the deep veins still remain the cornerstone of drainage.
Right.
What we are really concerned about the deep veins, and once they are destroyed or blocked, the patient will be stuck with lifelong swelling, redness, sometimes in worse conditions, very difficult to treat venous stasis ulcers, discoloration, itching, and it's just miserable, and it lasts a lifetime.
Right.
And if the more proximal veins or more higher up veins, closer to the so-called iliac veins, when the larger ones are blocked, the whole leg can be significantly swollen, and there is really no effective treatment that we are aware of. You can tell a patient to wear knee-high, thigh-high compression stockings. How many people are going to do that in Louisiana weather?
In the heat.
Wearing thigh-high compression stockings all their life. Just think about it. So it's really a significant problem that needs to be prevented, that needs to be actively diagnosed, that needs to be actively intervened, so at least we can minimize the consequences of long-term venous phlebitis and all these sequelae we are talking about. And of course, certainly wound care efforts and different types of skin grafting, and all these are very sophisticated things that have emerged. But still going back, prevention, early diagnosis, early and effective treatment. And I think as some of the modalities we are just showing here, there are definitely options that are available both at Opelousas General Hospital. Again, not too many physicians. I'll have to take pride in saying that in our institution we have, as always, kind of embraced some of these technologies. And of course, we embrace some of them go by the wayside, but some of them do shine. All these predominantly, again, used to help the patients and raise the goal of talking about sitting here in these TV shows is raise the awareness, first, of the problem, and second, the treatment options that are available, and then maintaining a high degree of suspicion so they can come to their doctors and help the doctors make the diagnosis by reaching out to the doctors. And then once they come to us, we are really kind of on top of the pyramid here somewhere, and it goes through many channels and gets to us where we use these fancy tools and all that to help. But if they don't get to us, there is no way for us to help.
Correct.
And if they get to us too late, there is no way for us to help. So the goal is to really kind of just raise the awareness where patients first come to the physicians then refer to us, and we can keep on talking about this again, certainly for the next issue, as well as the other call-in program for the next one or two events. And it's a 1 hour has gone by within no time, and I know it's a beautiful weather for audience to be tuning in and watching TV, but certainly when they do tune in and talk about this, I wish they learn a lot about deep vein thrombosis and PE. And I want you all to make some closing remarks about some things that stick to the patients.
One of the things I would like them to remember is it's very simple. Sudden onset of shortness of breath. There's a chest discomfort that could be similar to a heart attack, but there's one characteristic. The heart attack chest pain gets worse with exertion and relieves by rest. This one will not relieve by rest. It does get worse with exertion, but it doesn't relieve by rest. Think if you have a sudden onset of shortness of breath, chest pain, and you're coughing up blood-tinged sputum, you need to get to see that doctor, preferably the emergency room. Prevention: smoking, obesity, use of supplemental estrogen, etc., all the things we mentioned here. Clay, you want to say some remarks?
The other thing is for the audience is this is not a hospital-based disease process. People get these all the time. You hear about, it was big in the news a couple of years ago about long transatlantic or long flights, long train rides, long bus rides, anything that is going to keep the patient in a sitting position for a very long period of time, i.e. over 2 hours. Any travel should be interrupted by getting up and moving every 2 to 3 hours.
Absolutely.
And that is key. They now have the anti-thromboembolism socks for travelers to wear that are very tight, the knee-high type of socks. So just some things to throw out. It can happen to just about anybody, even very healthy people get this.
Absolutely. Strolling even in the aircrafts, rather, you see these charts showing those little flexion extension exercises of the feet, walking and strolling and keeping yourself well hydrated, taking even an aspirin if you expect frequent prolonged flights. And I also heard that, I didn't read this myself, but I think Serena Williams, the tennis player, experienced deep vein thrombosis and pulmonary embolism.
That's correct.
So nobody is immune to formation of deep vein thrombosis and pulmonary embolism. And certainly as we age and our health risk factors go up, we are at even higher risk of developing deep vein thrombosis and pulmonary embolism. So with this, we'll close the show, and we'll definitely encourage our audience to tune in every month, second Tuesday of each month, 6 to 7 p.m. to a live call-in show from the heart. And I want to say good night to our audience from Opelousas General Hospital and Cardiovascular Institute of the South.
Join us for From the Heart from Cardiovascular Institute for their next live show, April 12th at 6 p.m. on RTV KDCG.